I am Jim Turner. I'm the Dean of the College of Osteopathic Medicine at William College University, and moderator for today's panel. The way we're going to do this, I'm going to take about 30 seconds to introduce each of the panelists. They're going to have about 15 minutes of talk, and that should give us about 10 minutes at the end for questions. First panelist is Dr. James Young. He is the Cleveland Clinic's Chief Academic Officer and oversees research and education for one of the world's largest healthcare consortiums. He is a professor of medicine and has served as the executive dean of the Cleveland Clinic Learner College of Medicine at Case Western University for the last 10 years. He has also served as the chairman of the Endocrinology and Metabolism Institute, the physician director of the Philanthropic Institute, and co-founder of the Kauffman Center for Heart Failure, where he holds the George and Linda Kauffman Chair. His research has been numerous. He's published 150 clinical trials as author, co-investigator, 700 manuscripts, and several textbooks. He's a member of the National Diabetes and Obesity Research Institute Board of Directors at Tradition, Mississippi, where he served as a driving force behind the establishment of that organization, serving as the chair and member of the Board of Directors. Dr. Young.
Well, my thanks to the Dean, Dean Talk, and so we understand the challenges and the issues that are here. I particularly thank Governor Bryant for putting on the conference and actually allowing us to be down here, and as he mentioned earlier, it is a privilege for the folks from Cleveland Clinic to be down here, and I appreciate very much my team with what they're doing, and I'm going to make a very important point in a minute about exactly what it is that we are doing. But I'm going to be brief, use Winston Churchill's comments about be sincere, be brief, and be seated, and hope to make a few focus comments that may rattle a few cages a little bit. But one of the reasons we're down here in Mississippi is that y'all are doing a tremendous job with putting together a challenging issue in healthcare today. And we're going to be talking about workforce issues in healthcare today. And healthcare is changing. It's no longer a gladiatorial sport. Again, Governor Bryant did a couple of things. One, he characterized the gladiatorial sport that healthcare was when he was born in, what was it, 1954? So that makes him a 64-year-old Caucasian male looking much, much younger than his stated age. I think that's how Dr. Hayes would describe him. And the systems that we have today have to change to be able to address the problems that we have. Darren did an incredible job talking about the opioid crisis, and this is huge. And I'm going to focus around diabetes and obesity, which has been a longer-standing recognized crisis that we're trying to address with the National Diabetes and Obesity Research Institute down at Tradition outside of Biloxi. So that's pretty much why I'm here. But I wanted to caution everybody that they should remember the statement that came from a fairly recent Nobel Prize winner. He won the Nobel Prize a few years ago, just picked it up last year. Bob Dylan, everybody knows Bob. One of his famous lines that was cited in the Nobel address that he gave was, "You better start swimming or you're going to sink like a rock," meaning that you have to change, meaning that we have to go into a different type of direction. Now, Governor Bryant characterized many of the things that are going on in Mississippi. We have several things that parallel that in Ohio, but I was energized by looking at his thoughts. But also remind everybody of something that Niccolo Machiavelli said. Everybody knows Niccolo from The Prince. Anybody that's been through school has been subjected to that. He was a Renaissance kind of guy. Things went well, didn't go so well, but he commented in the book, The Prince, there's nothing more difficult to carry out, nor more doubtful of success, nor more dangerous to handle than to initiate a new order of things. So that's what's going on, the economic development, the focus on things like diabetes, obesity, the opioid crisis is there. And how are we going to do it? Well, what we're going to do is leverage things that we already have, which are caregivers, which are new concepts, which is open-mindedness, which is a willingness to change from that physician-oriented gladiatorial sport to a team sport, a rugby scrum, if you will, and focus on some things that came out of a recent book by General Stanley McChrystal, a book called Team of Teams, where he talks about taking elements in any organization and linking them together in a matrix model that can capitalize on what's already there. For me, with private practice elements, we have small group practices, we have large group practices, we have academic practices, we have hospitals, and we have education. And you heard, again, from Darian, very importantly, we need to change how we do the workforce. I'm a physician, I can say this, fellow cardiologist sitting down there, Clay. No longer can we have a physician-dominated, mano-a-mano kind of attack on a disease. It takes a tremendous amount of individuals to create the team, and we need to rely on our nurses, nurse practitioners, PAs, pharmacists, diabetes educators, diabetologists, and coordinate that by linking these centers of excellence, which we're trying to do within DORI and with our partners and with other industrial-based components, particularly something, again, that Governor Bryant highlighted, and I don't think he highlighted it enough. Sorry, Governor. And that is what Mississippi has done with their distance health programs, the telemedicine ventures. And something that needs to be focused on is how to utilize that, how to expand that, how to get broadband everywhere so we can use the highest level of technology to get access to the patient so that we can see a diabetic patient not once a month, not once a year. We can see them every week, particularly if we utilize our nurse practitioners, our nurses, our pharmacists, in addition to the physicians. Now, why is all this necessary? Simple. 23 million Americans have diabetes. 85 million have prediabetes. If you look at deaths, 80,000 directly related to diabetes, and 200,000 have diabetes as a component element to it. 7% of non-Hispanic whites have it, 15% of American Indians have it, and overall, if you include prediabetes, it's up to about 20%. And if you look at the total cost, $327 billion. Of that, some $80 billion just due to lost days of work and an inability to perform. Now, obesity, being overweight, technically being obese, according to NIH criteria, 2 out of 3 adult Americans, including me. I struggle a little bit. So the intimacy of obesity and diabetes as it relates to the overall difficulties we have is huge, and we must figure that out. And so if we look at where we need to be going, it is to change the structure. We need to declare war, a war that we can win, not like a lot of wars that we are currently dealing with, but a war on diabetes and obesity, just like we have a war on opioids now. And we need to create a different formation of teamwork with nurses and pharmacists and dietitians, as I said, and we need to rely on new technology to capitalize on the new workforce that can only come out through education, organization, and teamwork. So, as Winston Churchill said, I'm going to be seated, but hopefully have sparked some thoughts and provided a focus that we can use to create the conversation. Thank you.
And again, I'd like to save the comments to the end of the panel, and then we'll direct them all together. Joseph Achanti is the CEO of United Health of the Gulf States region and is dedicated to helping people nationwide live healthier lives lives by simplifying healthcare experience, meeting consumer health and wellness needs, and sustaining trusted relationships with healthcare providers. United Healthcare contracts directly with over 1 million physicians and care providers and 6,000 hospitals. He also developed and executed small business plans and key account public sectors in individual exchanges. He brings today over 20 years of experience in healthcare, financial services, and experience to today's discussions. Joe?
So first, I just want to recognize Governor Bryant. Your commitment to this Economic Council and as it relates to the industry and healthcare is just phenomenal. And you know, I'd be remiss if I didn't thank the involvement that I've seen come from the Mississippi Economic Council. About 2 months ago, we had a platform where we really thought through as a collective group of leaders and talked about barriers and ways that we can get more skilled education in this state to be able to get and translate that into technology and to healthcare. And so I applaud Mississippi Economic Council and also the Mississippi Business Group on Health. We had a session a couple of weeks back. We had North Mississippi Health System, St. Dominic's, and also the Hospital Association. And we were talking about how as a community do we work together to collaborate to help people live healthier lives. And so I applaud all of you in the audience for doing that. And I feel like I'm forgetting someone here. Usually you would thank your spouse at this point, but I guess my spouse in the industry would be Commissioner Cheney. So thank you very much, wherever he is. I did see him outside. That's certainly a love-love relationship. So thank you, and he's certainly one of the most fair and passionate individuals that governs our industry and what I've been exposed to, so thanks for that. So I thought Dr. Young did a very good job of calling out a couple of examples to get your thoughts and to stimulate your thoughts. Now I'm going to go off script here a little bit, but he had brought up General McChrystal's book, Team of Teams. I hadn't planned on really mentioning that, but it generated a thought. And so one of the key things that came from that book, and he's written a few, is collaboration and adaptability. And he went through, and I had the honor of hearing him speak actually twice and meeting him. And what he talked about is an example where, as the general, when they were going on night raids or midnight raids, it would have to follow the chain of command to get his authorization to actually go in to a city or a town and fight and combat the enemy. And what they found is they were always late. And the reason why was because within the structure and the confines of the military, they had to follow that structure. That's the way the hierarchy's been for years. So what he did is he took a step back and said, you know, we need to be adaptable to the people that we are combating and fighting. We know that they have different cells and different pockets, and they're never really predictable at all. And so we have to be in a situation where, you know, if you feel it is the right thing, we're going to empower that local lieutenant to make sure that they make the decision to go and proceed with the raid. And he said that had changed a lot of the way that the approach is taken in the war. So that was certainly a good book, and I would recommend you read that. It's certainly not a light read, but something you'd want to look at. So I'm just going to talk a little bit about you know, collaboration. From my perspective, you're going to hear more about the ways that I have been collaborating in the state of Mississippi with health systems, with employers, and how we make sure that we are putting their employees, our patients, some of you in this room, at the center of that. So about 3 years ago, there's a quote that stuck with me, and I think about this every day. The quote is, "We are in the midst of an unprecedented revolution in healthcare." Think about that. Unprecedented revolution in healthcare. That was 3 years ago when that quote was published. I think about every day the last 3 years how much has changed from technology to all of the rampant need for consumer information, big data repository, claim information, transparency information. It actually can become pretty overwhelming. But the two things that I've anchored myself on, and as I look at the industry, is one, there is an absolute need to tame cost inflation. That continues to be a driver, but while doing that, you need to increase quality. And the second is really the need for consumers who have a huge appetite now for digital health. And I know Governor Bryant talked about telemedicine. I applaud this state for what we've been able to do in that space, particularly University of Mississippi Medical Center and the work that they're doing. But if you break down and peel the kind of onion, if you will, on the cost inflation, I mean, think about this. There's $3 trillion annually spent in healthcare. That's 18% of our gross domestic product. $1 trillion of that is the medical payments between health insurers and health systems. Traditionally, that's been based off of fee-for-service. Patient goes in, is seen, the provider is reimbursed. There's not necessarily, though they're getting the right level of care, I have many great physicians and many health systems that I work with in this state and in Louisiana and Alabama, but there's nothing in that model that actually incents outcome or changing outcome or increasing quality. Second item under cost inflation is chronic condition. We've been talking about it, obesity, diabetes. We have type 2 diabetes, hypertension, heart disease, prevalent issues in the state of Mississippi, which contribute to about 75% of our costs. And then the last thing under cost inflation really is still gap in care in patient experience, non-integrated systems, or lack of collaboration. When I think about the consumers and their thirst for digital health, I think about the health technologies, I think about telemedicine, I think about the need for health apps on your iPhones, I think about virtual visits. I also think about all of the different sets of electronic health records coming from data. And then you also look at consumers expect a lot, and they should get a lot because it is their health. And they certainly want to live long, as do I. So what are you going to do? If we don't address those two issues, we're going to continue to have an epidemic. We're going to continue to have a disjointed system, transactional, reactive, not preventative. So in my opinion, there is truly a reason to get up every morning, and it is to address those common issues. And that's what motivates me. It motivates me to interact. And so I thought about what I would share on what the solution is. So I kind of shared some of the things that really are driving that undercurrent. I thought about collaboration within the industry. And I thought about levels of collaboration. When we don't have collaboration, I think to traditional conversation between myself and so many in this room, but also from a health system perspective, it's more about rates, more about transactional detail, and certainly there's a lot to be had there. But when there's just a little bit of collaboration amongst us, we're able to come together and put things on the table like performance-based contracts, which is essentially you're looking at a few quality metrics, and there's going to be a portion of incentives, extra dollars, that can be identified for a health system between the insurance carrier and the employer can win on that too. Bundled payments is another space as it relates to looking at episodic care. I look at spine and joint, and you look at centers of excellence in the state of Mississippi, and you identify an area, which we have a few, where they have the ability for all of the tests, the diagnostics, the surgeries, and the rehab. And then we identify a bundled payment for that. We've seen 40% savings in spine and joint in the last 2 years in the state of Mississippi because of bundled payments. Now, the last piece I'm going to touch upon is where you have a tremendous amount of collaboration. And I would focus certainly here in Mississippi. I have responsibility for Louisiana and Alabama as well, but here in our own backyard, we've been able to put together accountable care organizations. And what is that? You've probably heard that term. It's been around probably for about 5 to 6 years. It's in the commercial business and the Medicaid business. It is taking a stand along with a health system to identify high-performing physicians and specialists, working in a geography to identify a population of patients, and through that, identifying core quality metrics. Not quality metrics that I, as an insurance carrier leader, want, but quality metrics that's needed individually in that geography and needed for that health system based off of their expertise. And I can tell you, we've been able to accomplish that in many ways. We are seeing right now in this state the ability where we have a 13% increase in compliance on adult wellness exams because of an accountable care organization. We're seeing 12% increase on compliance because of breast cancer screening of women between the ages of 50 to 74. And that is compared to populations that are not in an ACO. So when we attribute those members, along with the health systems, and we have the docs, and we have the ability to manage that population, we are seeing results. We are seeing tremendous opportunities to address gaps in care, high-risk patients, pre-diabetics. And I would just close with this, is that, I think about, why are those, or how do you get to increasing adult wellness exam, preventative care, breast cancer screening? How do you get to increasing quality metrics in an ACO and a non-ACO? It takes partners. It takes Hattiesburg Clinic. It takes Forest General. It takes North Mississippi Health System. It takes Rush Hospital. It takes St. Dominic's. These are core health systems that we are working with and have been active with in the last several years. And it is a tremendous opportunity to work with them and see how we can increase quality, lower costs, and improve outcomes. So I would make one last comment and just let you know that when we get it right, all of us win. Health system, patient, employer that has the members or has the employees, and the health insurance and the whole system work in the state of Mississippi wins. But I mentioned those several partners. We have roughly about 100 of those different arrangements, from performance-based contracts all the way to accountable care organizations in this state. And we are learning several things that I would continue to ask you in this audience to continue to collaborate with us on. And that is, one, we have to strengthen the primary care physician bench. We have a lot of individuals who are retiring in this state. We have the ability where the primary care physician is the quarterback within that model. They control the care. They are in the community. They're also driving greater access to care. So we have to continue to focus on how do we make telemedicine, virtual visits, really part of that interaction with that member. The second is actionable data. We need to make sure that real-time data is being provided to each and every physician that is seeing a patient to make sure that they can identify that high-risk patient and we can help them. And then the last is high level of physician and certainly executive level of engagement. I can tell you that it's been a pleasure and honor, and I really thank all those health systems that I had mentioned. Each one of them had taken my call 3 years ago when I got into this role. And because of them taking the call, we've been able to collaborate here more in Mississippi and make a difference. So thank you.
Our next speaker is Dr. Kim Hoover. Dr. Hoover is the Dean and Professor at the School of Nursing at our own University of Mississippi Medical Center. She's responsible for both campuses that include all the way from bachelor to master's, PhD in the nurse practitioner programs. As Dean, she provides a strategic leadership to the School of Nursing with overall oversight for quality of the education, research, clinical setting, practice, and service. She runs 10 rural clinics, including the mobile primary care specialty operation that they have. She is very active in the national level, facilitating strategic planning for where her profession is going and the shortage and need of nursing in the future. Dr. Hoover.
So we didn't have an opportunity to collaborate much when we were talking about having this panel put together, but While I am going to talk about nursing, I think I have an opportunity to tie some of these things together. We've heard a lot about collaboration and communication and telehealth and that sort of thing. And so today I'd like to talk with you specifically about workforce data, about current issues in developing the right nursing workforce, and then some suggested solutions to those issues. So as you heard one of our speakers say earlier, nursing shortages do cycle around about every 10 to 15, sometimes 20 years. So it's no surprise that we're hearing these words again. But there are two camps. Some projections have us on showing us in the nation with a shortfall of nurses that's going to progressively get worse over the next 20 years. And some of the recent research that has come out shows that our area, specifically the East-South Central region and the West-South Central region, may not have quite the rapid decline that some of the rest of the nation has. Now, I'm not going to take a side on that. What I'm going to tell you, though, is that it's important to look at the evidence and it's important to look at the data. But during times of shortages, we do some things to help abate those shortages. We bump up our marketing, we begin to look at innovative delivery methods, and of course, we usually bump up pay for nurses. More people become interested in becoming a nurse, and the tide starts to turn. But in this case, we're actually faced with some unique situations that limit our ability to actually respond to nursing shortages. One of those is a lack of qualified faculty and a lack of precepted experience in healthcare facilities that we need to train our nurses. And as at the same time a significant number of nurses are reaching retirement age, our own aging demography in the state of Mississippi means that we're going to need more care, chronic disease care, more geriatric care, and primary care. The Board of Nursing licensure data shows that right now we have about 51,000 RNs who are licensed in the state of Mississippi. And only about 7% of those licensed RNs are advanced practice nurses, or APRNs. The 2016 data from the AAMC shows or indicates that there are only about 1,250 physicians in the state of Mississippi who are practicing either primary care, pediatric, or geriatric care. Now, we have to be careful about interpreting such broad data when we're looking at our nursing workforce, because without more specific drill downs, we can't really tell, or it's difficult to draw conclusions about whether there's a shortage or whether there's actually a maldistribution. So we do know that often in areas with economic decline, that there can be a maldistribution of a lot of professionals. There aren't opportunities for people to take spouses, to have good educational opportunities for their children. So I think there are some issues in developing the right workforce, and it can be put into four categories: education, the needs of our state, technology, and funding. So in terms of education, I've already mentioned that we have some issues around clinical sites, around precepted experiences, and around our faculty and space, but there's also an overwhelming amount of information that needs to be taught that simply can't be memorized. I listen to Dr. Radio on satellite radio sometimes, and I heard a physician talking about being the star student in her class. She said that when she was a resident, she could memorize anything. And she said, I was the smartest student in the class. She said, if I went to school right now, I would no longer be the smartest student in the class because it wouldn't matter what I could memorize. She said, not only would it not matter, there's so much out there, I couldn't find it all if I wanted to memorize it. So we need to be aware of that. And there's a need for care across the continuum, not just for care across the continuum of age from birth to death, but also from acute care to the community. We've been talking about moving more care into the community, yet our own educational programs still spend most of their clinical hours in hospitals and in acute care, where they have acute care experiences. So with regard to needs of our state, Mississippi, as you've heard several speakers say, has an ever-increasing need for primary care providers. We need primary care providers who are skilled in chronic disease, skilled in nutritional care. We certainly need mental health care providers as we listen to people talk about the opioid crisis and chemical dependency. So these are huge healthcare issues today. But you can't bring up the need for these providers without also acknowledging that Mississippi does have more restrictive nurse practitioner practice laws than about half of the nation. Now, we've known for some time that communication is the most common cause of medical error and harm. So resolving differences at every level, including the policy level, is crucial. Now, technology. Most of us have access to more technology and decision support tools than we could possibly want for more, and this is to improve the quality of care. We don't really see the needle moving as much as we need to in terms of translating to better quality. With more ability to share patient records and information, care coordination actually ought to be enhanced. Yet when we're doing handoffs from one facility to another, from one provider to another, I know many of you have experience going from one provider to another and getting there and them not really knowing what it is that they needed to know about you. So that's still another challenge for us. And then funding. The uncertainty in funding models really could result in consistency in our staffing patterns, in our hiring practices, that can contribute to a disgruntled workforce and actually mean that there's less encouragement for people to go into nursing when they hear their mothers, their brothers, their sisters, husbands, wives talk about not wanting to go into these facilities. And they might not want to go down those career paths. And we've seen a loss of scholarship dollars, certainly funding for students as the cost of higher education rises, and that means that some people who might meet the criteria to come into nursing programs are not going to be able to afford it. So what then does it take for us to develop the right nursing workforce prepared to care for Mississippians? I think the very first step is examining the data and determining areas that may actually have shortage versus those that have maldistribution. So nurses and other professionals, again, aren't willing to go to these areas that are economically depressed. So getting care to these populations means that we're going to have some community partnerships and innovative delivery of that care. You've heard some of the other speakers say that. The UMMC School of Nursing partners with both urban and rural communities where access to health care is limited. We work with the Jackson Public School System, we work with the City of Jackson, we work with community organizations, the South Delta High School System, and that school system, and others to provide primary care and health care education to children's parents and also to the staffs of those schools. And in the process of doing this, we expose our students at all levels to community-based care, building trust in these communities first, and then engaging with them in community design and decision-making for better health for that community. However, you know, just like any of us, we can't be everywhere at every time. So how do we get care to these people? Well, we partner with our Center for Telehealth and our School of Medicine departments to set up telehealth delivery. Our Telehealth Innovation Lab in the School of Nursing is being used to teach our nursing students and our nurses, our nurse practitioners, to learn how to use telehealth for the delivery. We're also training community health workers and community health advocates. These are extenders. They stay in the community. They help monitor. They help encourage those who have chronic diseases, people who have diabetes, hypertension, cardiac disease, and that sort of thing. So workforce preparation means that we have to have the right mix. With limited primary care providers in our state, and actually across the nation, the need for family care, the need for geriatric, pediatric, and mental health nurse practitioners is really great in our state. While we are preparing those nurse practitioners, we're going to have to find some common ground on which to compromise and begin to loosen our restrictions on practice that could actually expand some access to quality care. That means we're really talking about communication when we talk about collaboration. That's certainly a more complex issue. We know that K-12 education needs to focus more on written and verbal communication skills. We want to prepare our graduates to care for families and for the communities in which they go. We want them to be on community leaders in community centers. We want them to be on boards. We need them to be in the legislature to lend nursing's perspective to some of the solutions that we need for the state of Mississippi. So if communication is at ground zero, then we've got where the practitioners are meeting to collaboratively care for patients has to start with education. We absolutely have to have disciplines working together early on through interprofessional education, teaching those advanced skills in communication, teaching each other how to share crucial conversations when the outcome may be a person's life. So we set up some scenarios through simulation. We do that through virtual reality. We do that through standardized patients, where they're actually actors who are doing this for us, so that they leave these programs practiced about what to do when faced with certain situations, and then how to do that in a respectful manner. In healthcare today, we have an overload of information and data. So what is it that we do with all of this? When you leverage data for or actually just information for our patients and Mississippians, we do that for the benefit of our health. These benefits are actually going to be realized in better health. That's going to mean saved healthcare dollars. It's going to be saved wages when people don't miss work. And it's actually going to be better educational outcomes, certainly when our school children are able to stay in the seat in school and not have missed days. They're going to have better opportunities when they go to have better educational outcomes. So for us in nursing, and I believe actually in all healthcare providers, it's important for our nursing students and our nurses to be able to do three things. That's to ask the right question, to be able to find the right information, to answer that question, and then to be able to make the best decision that we can make based on that information. And I know that sounds simple, but it's actually a complex task in today's world. We're constantly bombarded with more information than we could possibly take in. And honestly, we probably don't need to take in a lot of it. Some of it's just junk. But we need to be able to listen when our patients describe to us what they've read, what they've heard, and then respectfully point them in the right direction. Our workforce does need to be able to leverage that data to help make the best decisions, but to also let our populations, our communities, our patients be able to use that data in the best way that they can. So the last point I want to make today is about funding. At the state level, we're going to need qualified faculty to do all of this, and we're unable to pay faculty what they can make in practice. That's a real issue. We struggle to attract and retain the brightest and the best. We also know that restoration of our loan scholarships for nursing would help us keep our nurses here. We have physician and dental rural scholars programs. If we could expand those to include nurse practitioners, we could probably have the desired effect of improving healthcare access, and certainly I think the economy of rural Mississippi. At the national level, we need funding for graduate nursing education, such as that's provided for our graduate medical education. And so I think that needs to be reconsidered with some, there have been large demonstration projects, but not smaller ones in different areas of the country. So to reiterate, we need to look at our best evidence, our workforce evidence and other evidence. The health of Mississippians must be in the mix as we make our decisions about workforce readiness. And if we don't all come together soon, we're going to miss the opportunity to put Mississippi on the map as the state with the most improved health outcomes rather than the state with the worst health outcomes. So workforce readiness for the largest number of healthcare providers in the state, nursing, means more than just cranking out more numbers. It means putting the right mix of engaged practitioners and leaders out into our communities and helping to shape the best health and economic policies for our state. Thank you.
I swore I wasn't going to do this, but all three of our presenters brought up the fact that we need more people going into primary care. And that is William Carey University College of Osteopathic Medicine's mission. And I'm happy to tell you that the U.S. News and World Report ranked us as #3 in the nation among all medical schools in the nation for the percentage of our students going into primary care. Thank you. Questions, please. Yes, ma'am.
So, as a person who works for a company who has our own company-sponsored family health centers near site, I'm often thinking about how we take and really establish those and working to internally to get that access to as many people as we can. And as I hear the presentations up here, it's apparent that our next step is really those community partnerships. So when I hear about the diabetes and obesity foundation and the work that you're doing, how do you envision a partnership between a company like ours and the work that you're doing?
Yeah, well, maybe I can take that question. Are we up on the microphone? Do we need to turn this on? There we go. All right. So this is a complex problem, and in McChrystal's book, he talked about complicated versus complex, and they're slightly different. And if you heard what I said about we have existing elements that are out there, we need to deliver care paths and curriculums that people agree to and want to adhere to. And our philosophy is to work with an entity that can bring in coordinating elements, and those can be group practices, as you alluded to. Those can be hospitals, which we are trying to do through NDORI, the National Obesity and Diabetes Research Institute, and try to get them on platforms that we have tested at the Cleveland Clinic and have demonstrated some effectiveness. It's early. We don't know exactly what the right system is. But if you can take these different points and then link them in an interactive environment, we believe that you can then pool data, data's power, and understand the difficulties of diabetes and obesity a little bit different and a little bit better. And so our idea that we're affecting in Ohio and also here in Mississippi is to grow this organically and provide clinical support to be able to get out and deal with the challenges to get patients to lose weight, to control diabetes a little bit better, not ignoring the importance of the basic science research, but capitalizing then on the power of data. One thing that we've done early on is we've gotten our affiliates now with NDORI to participate in a national diabetes registry that the American College of Cardiology and the American Diabetes Association has established. So really for the first time we have a different kind of database that gives us information about what I call the diabetes belt. And again, people sometimes say, well, what's the link between Ohio and Mississippi? And if you look at the counties that have the highest incidence of diabetes, it forms a belt. It actually begins in Alabama, goes through Mississippi, Louisiana, Arkansas, up through Virginia, up through West Virginia, and then the belt buckle is southern Ohio. So we're all connected and we're all linked. That database is going to give us a tremendous amount of information about where to attack the problem at. Those are just some concepts that we have.
Yes, sir.
Dr.
Thank you.
When I mentioned what is here already, the public health networks are obviously one of them that's critically important. And Dean Hoover also mentioned another thing that is absolutely essential and alluded to things that University of Mississippi School of Nursing is doing, and that is, it was kind of buried in her comments, but boy, I picked up on it. It was interprofessional or interdisciplinary education. Again, Clay and I are cardiologists and docs, so I can say this. Docs don't always know how to work with other people. They don't know how to work very well with our nursing colleagues and our public health colleagues and whatnot. And so one of the things that I know Dean Hoover and her programs are doing, and we're trying to do up in Cleveland, is change that paradigm such that it's not just a medical student working together. And in Cleveland, talk about some costs, Governor. We got a $500 million, 500,000 square foot, that's, pretty big dollars, putting into a new health education campus that is a partnership with Case Western Reserve University. There's going to be 4 professional schools in there: Bolton School of Nursing, Cleveland Clinic Learner College of Medicine, CWRU School of Medicine, the School of Dental Medicine. We'll also have a PA school in there, and liaisons with our pharmacy schools, and we're going to be in the same building sharing curriculums in an interprofessional, interdisciplinary way. Now, we don't know if it's going to work, but we'll see. Pressure's on me because that's a lot of money. So hopefully we can deliver an ROI on that. But public health is an extraordinarily important aspect of things.
Yes, sir.
So one of the things that we're facing that's a challenge, and I definitely believe in collaboration and communication, is the electronic medical record. That's a huge cost to hospitals and practices, and we're struggling with that because there are a bunch of different records out there, a bunch of good records. I mean, the Epic is one, Cerner is one, NextGen is one, on and on and on. But they don't always talk to each other. And so I may have a patient, I see plenty of patients every day that come in and they may be from Columbia, for example. They were seen in an emergency room, they had some chest pain, they had a workup done, and then they're sent to Jackson to be taken care of, and I don't have access to those records. Or they may be seen by their primary care doctor and they want to get their lab work done. This applies to you, Joe, where do they need to get their cholesterol checked in his office or his or her office and in my office again? That's a waste of cost. So how is Ohio tackling that, and how does United Healthcare help with that? Because right now we're stuck with the collaboration between electronic health records.
Yeah, absolutely. So great question, Dr. Hayes. In some of my opening comments, I talked more about of the $3 trillion spent in healthcare, more on the $1 trillion that were coming between health insurer, employer, and the health insurance or the health system. The $2 trillion that I didn't really dig into, that's made up of technology investments, data repositories, CMS payments, specialty pharmacists. One of the things that I've seen, and I can speak a little bit for the industry, but certainly from United Health Group's perspective, is that I feel very fortunate as it relates to working in an organization that has Optum, which is an organization that drives off of healthcare delivery, expansion into home health, population health, and pharmacy. And I remember an aha moment about 2 years ago when we were at a leadership meeting up in Minnesota. And we were all with our local leaders. Obviously, I was representing Mississippi, and we were talking about not just the difference of the health systems like Epic or Lucerne, but we were also talking about the gentleman that was talking about public health. And we were talking about FQHCs and their platforms, and that might be less electronic, not integrated. And so, we have, as a company, particularly here in Mississippi as well, made investments as it relates to helping FQHCs or federally qualified healthcare centers to get more access to the information. So we are making strides there. But in regards to the health systems, to get common record, we have generated an ability to take in a technology platform that can take in any one of those platforms and provide one consistent view out, whether it be an Epic, or the others that are out there. So that's purely from a technology point of view. I think it drives consistency. But what's also key here, and the only way that we got to this from the 2 years ago when this became an issue, is we had individuals like yourself heading up cardiologists, working with the American Medical Association, working with those entities to come in and sit down with us and really identify, okay, if we have this geography in one state that's on Epic and then, another part of the state on a different platform, would it be best for us to provide, raw data? Would it be best to provide in a more kind of predictive view? What would be helpful? And so that's where we came up, and within the last year, we've deployed this in a couple of states where we have kind of one centralized platform taking in and making sure that it kind of converts to whatever that health system has.
So I'm really glad to hear that. And Dr. Hayes will know that the electronic medical record was the best thing to come out and the worst thing to come out. And now we're suffering the unintended consequences of a solution that we thought was a viable solution. And 20 years ago, I was interested in building an electronic medical record and went down and bought something called FileMaker Pro, which was this AirSat sort of computer program. We built one, and at the clinic it evolved, to answer your question specifically, into Epic. And we were one of the first big systems that pulled in Epic. Well, now I'm in Epic jail, because we can't get out of it, and we never will be able to get out of it. And of course, that's what Epic wanted. That's a good business practice. So between Epic and Cerner, really the two largest systems, they don't talk to one another. Now, at the clinic, we've been fortunate because we have mandated that our whole system go up on Epic. So we've done that now. So inside the system, if you're linked into it, you can see everything that's going on. Now, we have a quality provider alliance. We have private practice doctors working with us at the clinic, as well as our employed physician models, and so that's great. Epic has added something called Care Everywhere, which is a system that can communicate, though with some trouble, with other electronic medical records, and we have just begun using that. And when I'm doing virtual visits, long distance, now I can get information from a cardiologist that's got a question about whether or not a patient should be transplanted, et cetera, et cetera. It's hard to use, it's hard to work, but it's a beginning. The one thing that I think we can do, and from a federal regulatory standpoint, with all of the HIPAA laws, we need to perhaps loosen up a little bit, because that's one of the major inhibitors that we have with sharing of information, number one. And number two, we should mandate that the people that are building these EMRs create a talkability program, an interactive program. Watch out for Google Health. They're trying to do this, and they're trying to create a system where a patient can drive uploading their medical records in a central type of server that then can be downloaded to any one of the medical records. We'll see if that goes.
Could I just respond to that? Excellent points. I would even throw in Amazon as it relates to some of the things that are going on. And I think everyone's seen the announcement probably 7 months ago about Amazon, Berkshire Hathaway, JP Morgan Chase. Without getting into too much detail, we haven't spoken or driven as it relates to Google Health, but the premise of the technology is within the Amazon, Berkshire Hathaway, JP Morgan, is to create that one common electronic health, I would call presentation. So Dr. Young had mentioned sometime, we're getting to the point of providing the data, but it's a little bit clunky to get there. Well, we've been able to have discussions in discussions with Amazon to be able to kind of look at how do we work together, knowing that within Optum and the data repository we have some of the most largest data depositories of claim information, lab diagnostics, et cetera. So even though you have Google Health and some of those others, you know, we are proactively engaging and cautioning because we don't need more models. We don't need more electronic versions in the system. We've been doing this for years. So.
Hey, I've got a question. You know, talked about 75% of the expenses right now are pretty much spent on diabetes, I think cholesterol and blood pressure. And for the state of Mississippi right now, if a patient comes in and has a prescription for a 30-day maintenance med, in order to convert that over to 90-day, we have to call the physician. I know in Louisiana about a year ago they changed that, but I think it'd be a huge win to go ahead and be able for the patient to convert that. You know, when you look at the patients that could benefit from a cost perspective and an adherence perspective. You know, we're about 5% behind as far as adherence in Mississippi to the national average. But I'd like to know, is there a direct link to maybe Board of Pharmacy on wins we're having in the region that can help folks in the area be more adherent and healthier?
You both might have comments on this as well, but I would be able to address this from our perspective and what we're doing here in the state of Mississippi. So I think that, you know, the key piece there is, you know, if I'm on a maintenance drug, 30-day supply, I know that maybe there's cost savings, there's opportunities to get a 90-day supply. Why can't I have the ability, when I'm at the pharmacist, why do I have to go back to the primary care physician? Right, fair enough. So one of the things, and again, I'm going to get, I apologize, this is going to be a little bit of a commercial for United Healthcare, but that's what I know. And so we have a thing called MyScript, and it's an online tool that the pharmacist and the primary care physician of that patient both have access to. And so in there, they would have the data of information that identifies the maintenance drug, identifies, you know, it's going to be ongoing. And the pharmacist online can look this up, check this with the patient at the pharmacy, check that real time with a kind of what we call through our ongoing data repository that says, this physician approved this maintenance drug. We know it's one of the 32 kind of common maintenance drugs, and it's not narcotic, opioid, et cetera. They will get a real-time authorization back at the pharmacist to give you a 90-day supply. And that takes the frustration, and it provides truly consumer satisfaction. Now, we've tested that in certain pilots, and we're still working out, you know, certain opportunities to learn from, but I do think we're making progress in that space.
Yes, I have also a question. I'm Barto Burguera, Cleveland Clinic. Dr. Young is my boss, and Joe Canicero is my boss in tradition. I just want to make a point regarding the importance of obesity. You know, I have seen endocrinology, I am an endocrinologist, I have seen patients for the last 25 years. I need to still see the first patient who develops type 2 diabetes who has not developed obesity first. Okay? So we were talking about cost. The cost that we invest in taking care of patients with type 2 diabetes, hypertension, hyperlipidemia, depression, and osteoarthritis. But all those patients are developing these complications because first they have developed an obesity disease. 70% of the population pretty much have that disease. And we really, I think, we need to change our paradigm and the way we take care of these chronic diseases, centering our efforts on taking care of the obesity. Because we know that when patients lose weight and they improve their diet and they become more physically active and we help them with medications and even they undergo bariatric surgery, they do much better and all these other comorbidities get into remission. So we're investing a lot of money in taking care of the consequences of obesity, but very little on taking care of the primary cause. And I think to me that's very important.
I want to thank the panel. I want to thank our wonderful governor, and I want to thank Dr. Hayes and his committee. Scott, you have something? I think next on our agenda is a break, so.